So hello everyone, welcome to the finale of our Global Public Health Challenges and Opportunities Insight from the Expert series. And I'm really excited to introduce our speaker today, Professor William Maton-Howarth, who will be talking about communicable disease control, development of a national web-based system. Professor Maton-Howarth is an honorary professor at Brunel University in London. Bill has a PhD in solid-state physics and has experience of working in academia, industry, and government. While working at the Cabinet Office, Bill was responsible for informing national policy in relation to emerging technologies. On returning to the Department of Health, he was the head of public health research in the R&D Directorate with a wide range of responsibilities, including health promotion and health protection. Additionally, Bill took a lead on research for innovation and was closely involved in setting up a range of programs, including health technology assessment, invention for innovation, and the Small Business Research Initiative. So over to you, Bill. Thank you so much, and we look forward to the chat with you at the end.
Okay, well, many thanks, Adrienne, and that's a very kind introduction. Communicable disease control, development of a national web-based system. What I'd like to cover in this talk today centers on one particular R&D project that I had the pleasure to oversee when I was working at the Department of Health. Hopefully, it'll have some particular relevance and interest to some of the issues that we've all faced over this past year. Now, infectious diseases have plagued humans throughout history and even changed history at some times. Infectious diseases are disorders that are caused by organisms usually microscopic in size, such as bacteria, viruses, fungi, or parasites that are passed directly or indirectly from one person to another. In this table, I've included some of the important bacterial, viral, and parasitic infectious diseases. But there are many more, including pertussis, Ebola, Zika, dengue, yellow fever, pneumonia, meningitis, and even some that don't fit within those three categories, such as variant CJD. Over in the middle here, and you can see right at the top of the viral list that I've included, something that we're very familiar with over the last year, COVID-19, SARS, and MERS. And you'll see that these are very familiar to us and all relate to the coronaviruses. We know that infectious diseases have been really quite serious over many millennia. In the World Health Organization in 2019, 3 of the top 10 leading causes of death globally were related to infectious diseases. But for low-income countries, 6 out of 10 are due to infectious diseases. The battle that we're facing over the last year against the coronavirus is but one, is the latest round in the long-running battle that we've had with some of these infectious diseases. For a long time, this battle has been without really understanding very much about these opponents. We know that for some of the infectious agents, they've been around for millennia. For example, there's evidence of smallpox scars on Egyptian mummies dating as far back as 3000 BCE. This battle has toed and froed as human ingenuity has sought to understand the causes of these infections. And we've sought, as best we can, to find ways to counter the diseases caused. 2 particular important advances relate, firstly, to the work of Jenner in the late 1790s, that led to the first vaccine, one for smallpox. And secondly, to the development of antibiotics in the 1920s and the 1930s. These 2 tools in particular have helped considerably in reducing the severity and the impact from many of these diseases. They've also contributed significantly to major global programs attempting to eradicate some of these diseases. However, almost as soon as antibiotics were discovered, for example, genetic mutations in some of these microbes has meant that harder to treat strains have developed. And so far, there have only been two infectious diseases officially declared as being eradicated by the World Health Organization. Smallpox in 1980, after a major global eradication program over 2 decades, and rinderpest, which is an infectious disease in cattle and other ruminants, which was declared as eradicated in 2011. There have been other attempts under the aegis of the World Health Organization to eradicate other of these infectious diseases, but not successfully. A major program that was run under the aegis of the WHO for malaria in the 1960s and 70s has led to a major reduction, but in the cases of malaria, but failed to eradicate completely from some of the parts of the world. Historically, as we've seen then, the impact of infectious diseases have been devastating. We only need to look at the impact of the plague over many centuries. The first plague, and we've seen that there are 3 major plague pandemics over the last 1500 years. The first of these was in the time of the Eastern Roman Emperor Justinian I. And this spread from Egypt to Byzantium in 571 AD. It's not clear if and when the spread occurred to the outer reaches of the Roman Empire, including England, until we see reference made by the Venerable Bede in his Ecclesiastical History of the English People. Just move that a moment then. We see in his words, which are translated from the Latin, he wrote in his Ecclesiastical History, the pestilence broke out suddenly in the year 664, and after depopulating the southern parts of England, seized upon the province of Northumbria, where it raged for a long time, far and wide, destroying an immense multitude of people. Now, over the past 200 years, another highly impactful communicable disease has been cholera. There have been numerous cholera pandemics since the first one, which began in 1817. During the first half of the 1800s, there were 3 major cholera pandemics, each lasting some years, and little was really known about the causes or how to prevent it. 2 major competing views focused on whether transmission was airborne, the so-called miasma theory, or whether it was waterborne. And the work of John Snow in London in the 1850s made a major contribution to our understanding. At this time, London was in the midst of the 3rd cholera pandemic, and John Snow was studying a particular outbreak around Broad Street in Soho. He brought a more rigorous scientific approach to these studies, including drawing up maps, as shown on this next slide. This map, produced by John Snow in 1854, shows in black the cholera cases around Broad Street. And in this map, I've also overlaid on the map where around the streets, around Broad Street in Soho, the water pumps that were providing water to the population at that time. We have to remember that in the 1800s, early 1800s, sanitation was very poor. Water wasn't being distributed directly to the homes. And right in the center here, with this arrow, I've shown the water pump that was on Broad Street. And this was highly suggestive that the cholera cases were somewhat linked to the water distribution from this pump. John Snow used this to persuade the local authorities, this type of evidence, to persuade the local authorities to remove the handle from this particular Broad Street pump. And this helped lead to a reduction in the cholera cases. John Snow work of this type was very major contribution towards showing that transmission was indeed via contaminated water rather than via particles in the air. And this type of more scientific approach formed the basis of modern day epidemiology. Just 1 year later, after that activity of John Snow and that map, type of work that he did, in 1855, the English government established a new post of a chief medical officer for England. And Sir John Simon was appointed to this post in 1855. He was a doctor and was trained in public health. And the specific role that this chief medical officer was asked to undertake was to advise the government very specifically on the health of communities. It's particularly important to note that although that role, although based within a government department responsible for health, is and still continues to be a government-wide role. Now, I'm sure most of you, if not everyone, is able to recognize this chap, who's Professor Chris Whitty, and has had an immense amount of media attention over the last year in relation to the events relating to COVID. He is the current incumbent of that chief medical officer role, and the amount of media attention he's had is unusual, and I guess it's probably far more than he ever expected when he took over this role in 2019. It's very unusual circumstances, but if we go back to some of his predecessors, I wonder how many of us would actually recognize some of the earlier ones. Now, Dame Sally Davis, I would think probably many of you will be aware of and recognize. But if we go further back to the chief medical officer between 98 and 2010, that's Sir Liam Donaldson. And then 91 to 98, the CMO was Ken Kalman and Donald Aitchison, going far back. Now, I joined the Department of Health in 1990, so this CMO was actually the CMO at that time, but even I had very little recollection of actually coming across him. The role of the CMO is a very important one in terms of public health, but in political terms, it doesn't seem to have been very high profile, and the media exposure for the CMO has not been that particularly high unless there are very special emergency circumstances. Now, within government mechanisms, the CMO, in terms of the role for overseeing the public health and the overall population health, is critical. And to support that function, research is an important and integral part. For a long time, though, much of that support for the research was not within the remit or the control of the CMO or the government department. Within the UK mechanisms, the major funder for medical research has been under the aegis of the Medical Research Council, which was originally founded and set up in the early 1900s. And for the first 50 years or so, this was the major source of the advances in improving our understanding of the causes of disease and the ways to improve treatments. During the 1970s, there were many major government reports which changed this to some extent, and a lot of discussions in relation to the balance of the research between so-called blue skies research and the more applied research to support government departments was undertaken. And this started to change the balance. And within the Department of Health at the time, the CMO at that point of time made a case and managed to carve out a small budget to manage the research required to support the policymaking of the CMO specifically. The value of R&D to support the CMO's role was rapidly recognised, and this led to an increasing budget over several years. And this soon led to the establishment of a separately managed R&D function, which was independent of the CMO, but within the Department of Health. Now, at the bottom here, I've raised a number of questions that are related to some of these issues. They're not the focus of my particular talk, but I just wanted to make a cross-reference to some of the important work that Professor Steve Hannay has been involved with for many years. And at Brunel, he's been instrumental in writing many papers in relation to these relationships between the role of research and feeding into government policy making. But to move on in relation to the core of this talk, what I'd like to do is explain a little bit about my background in relation to the role I was taking at the Department of Health in the mid-1990s. At that point, I was lead for the public health research, and I was developing research in relation to many areas, including healthcare-associated infections and antimicrobial resistance, air pollution, skin cancer, and a number of other areas. But I also had a lead in relation to, because of my own particular background, I also had a lead in relation to innovative health technologies and innovative uses of information and communications technologies in healthcare. And I was particularly aware that at this point in time, public health overall was not especially high on the political agenda, and that the levels of funding for public health R&D were relatively low. But we did have a budget to take forward some of these major initiatives, and I was especially keen to try and bring forward some innovative technological developments that could have a positive impact on communicable disease control. In 1998, I was approached by a multidisciplinary team with some exciting ideas for developing a decision support system for consultants in communicable disease control. Now, from the earlier slides, we've seen how devastating infectious diseases have been throughout history. But it was not until the Second World War, when there was heightened concerns about the possible threats from bacteriological warfare, that a separate organisation was established in the UK. The Public Health Laboratory Service was formally set up in 1946 to take responsibility for the prevention and control of communicable diseases in the UK. At a local level, consultants in communicable disease control are responsible for the prevention and control of communicable disease in the UK. And the work of the CCDCs includes the reaction to an outbreak, real or otherwise, of a dangerous infectious disease, and the general day-to-day decision-making and management of data and information relating to communicable diseases. Much of this work is focused on risk assessment. A key part of this frontline role is for the CCDCs to identify outbreaks and to assess risk and to implement interventions. Making this call of when there is an outbreak is a very critical decision. For example, this could be to discount the case or to close a school or a hospital or a ward in a hospital or a restaurant. And in 1998, at the time this approach was made in relation to these particular interesting novel ideas, the role of the CCDC as a frontline service relied on a disparate flow of information at a local level and on their experience and skills specifically, but manually pulling together this data and interpreting it. And this approach prevented effective sharing across geographical and organizational boundaries, and often hindered early detection of particular problems that were emerging. So in early 1998, this multidisciplinary team, which included an expert in risk management at Bradford University, an IT expert who had successfully built a business in video games, but was looking to do something more fulfilling in health, and several frontline clinicians working for the PHLS in the Leeds area, approached me with ideas that they started to put together, and we worked together over a few months to put together a proof of concept for, and had tested it out at a very local level. It was at this point that they approached us at the Department of Health, and they were seeking additional funding to take this a step further. And this idea came through to me, and I arranged to meet with the team and learn more about the work. I was persuaded by the opportunities and encouraged them to draw up an initial research funding for consideration. And rapidly jumping over a 12-year period in this slide, the work that was eventually developed during a 10-12-year period between 1998 and 2010 was to apply some of the ideas of bringing together the work from risk management and taking a very frontline bottom-up approach to develop a way in which the professional knowledge and the practices of the CCDCs could be brought together in a system. And if we move on to a broad overview of how this system eventually looked, bear in mind that there were many iterations to reach this point, but eventually, after 3 or 4 years of workshops, a clinical consensus was approached by consulting with the whole range of CCDCs operating around in England to develop this core dynamic risk assessment model, which has 5 key attributes. On the bottom, you can see that the disease severity, the confidence of the clinicians, and their assessment of the likelihood of spread. And against each of those attributes, these 5 individual scoring mechanisms with the definitions and wording, which were very crucially honed over these series of workshops to reach clinical consensus. Essentially, the assessment process relied on identifying and assessing in this way, and then also judging the likely nature of the interventions that will be required and the context of the situation. So for any emerging outbreak, this was the basis on which the system would operate. Here, the context is an interesting one and was rather an extension of the approach that the individual clinicians were taking, and required quite a lot of discussion, bearing in mind that certainly some of the types of outbreaks that they might be dealing with at a local level could have national context and consequences. And the context was to be able to make a professional judgment of the likely concerns that might be wider than local. So whether there might be wide-scale media interest or potential concerns if the political situation was particularly hot. So, and with apologies, I'm jumping very quickly over what was many years worth of activity and development. The outcome was that on the basis of this type of approach, This system was developed over several phases and evaluated. And in January 2010, a web-based version of the system was implemented nationally by the Health Protection Agency, as it was then, in England. This was a great achievement in getting to this point, and the system, as it was called, HP Zone, was adopted by all of the 26 local health protection units, covering 9 regions in England and the National Centre for Infections in Colindale. Crucial for the deployment was gaining full acceptance from all of the frontline CCDCs. And this was achieved largely due to the development all along, having involved all the stakeholders as the system was designed and developed. Now, in this slide, I'm showing a very broad overview of the basis of the way in which this web-based system was operating. The situation as it emerged was put into the system, and using the risk assessment approach with backup knowledge information, the system allowed full communication and management of the events. And the next few slides, I'd just like to show very briefly an indication of how this earlier system during the period 2005 to 2010 was refined first locally in the areas around Leeds, and then developed for this national implementation by the Health Protection Agency. And quickly showing some of the screenshots from the system as it was in about 2008. This shows how the risk assessment process was entered within the system, and then how the system also provided immediately the type of mapping. If you recall the map that John Snow produced in 1854, the system here was able to provide exactly that type of overview mapping, case by case, plotted on local area maps, and provide that type of detailed information at a glance to allow major clinical decisions to be made. Here's an example of how the system was used in 2007 as part of that development in real life situation when there was a food poisoning outbreak of E. coli E0157, and the screenshot of how the system brought together information from a number of sources and very rapidly allowed the local CCDCs to identify the source of the outbreak, a local butcher's, and rapidly move in and take the appropriate action. And here's a slide to show, again, a screenshot of the way the system was used for identifying an outbreak of seasonal influenza in care homes. And on the right-hand side here, the range of types of information that was being brought together and supporting the decisions and actions and management of these incidents. And then another example here where the case of a hepatitis A was identified, and on the right-hand side, the range of types of information and guidance that the system was providing to support the clinician rapidly to identify whether and who to inform. And the system also provided the automatic connections, if necessary, to the health visitors or the nurses or the letters to the GPs. So this was a big step forward in terms of the technology supporting the clinical practices. Now, this takes us to the point in 2010 where a national system was therefore implemented and in use across the country. And within the Department of Health, I specifically championed this development through these various phases during that period. The key intellectual property for the system resided in two places. There's the software, and this resided with a small company that had been set up by the non-clinical members of this team, and the clinical IP, which resided with the Health Protection Agency. With this particular rollout to the Health Protection Agency as a customer, my formal involvement at that point ended. But I'd been closely involved in a number of discussions in those final 2-3 years with the team as those final stages of implementation were being taken through, looking forward to other further stages of development. But my role stopped because the system was now out into implementation, and the responsibilities for taking that further forward lay then with the Health Protection Agency. Cutting a long story short, this period of 10 years or so could have allowed further developments to have occurred in a way that may have moved some of these ideas more rapidly forward. But in my opinion, my feeling was that some of those opportunities were not taken by the Health Protection Agency. They were keen to continue the relationships and see the system used, but I don't think they invested sufficiently in further development of those ideas. The leader for the work and the main motivation for taking these ideas forward arose from the risk expert who was based at Bradford University, and Dr. Shaki Karazaitri. They maintained their interest in being able to develop the system beyond that they'd taken it to in the period up to 2010. And although they were working with the Health Protection Agency to maintain the development of the system to an extent within the UK, the more forward-looking ideas were not being taken forward in the way they had hoped and that I'd hoped. But what the team were able to achieve was to take some of those ideas to work with the Dutch public health system, where they had received a much more creative and forward-looking response. And in the last 5 years, they have been able to successfully work with the municipal health services in the south of the Netherlands, the so-called GGD's, and I'll leave you to make the pronunciation of the actual Dutch words there. They've been able to work with them in a very productive way and developed a number of very specific disease-focused systems based on this original system and this approach. And they've developed systems specifically for sexual health management, for TB management, a national influenza management system, and for travel health. They've also worked more recently with the Dutch system to develop a national dashboard for infectious disease control. So I'd like to thank particularly Dr. Karazaitri for providing me with a number of the following slides to show some of these recent developments. As I stressed, I'm not very closely involved with some of this recent work, but I've been monitoring how they've been able to take some of it forward. And within the Netherlands, they have contributed to developing a national dashboard for infectious disease control. And this system, as we can see here, developed in between 2017 and 2020, allows a national perspective of a range of the infections that are entered into the system, and to allow a national perspective to look at the changes of these particular diseases over time, and to be able to look at in a very wide-ranging way to investigate, inquire of the data. Here we can see how the data allows the central teams to look at specific diseases by different day, and to look at the data for specific diseases by age group, to look at and break down the data to particular units, the municipal health units. And so this leaves us to come to a point where we're very close to the work that's happening today, virtually, in the last year. With this type of capability in the Netherlands, one might be able to ask, one could be wondering whether something similar could be done for COVID. And so what I'd like to show just in these last few moments, the specific work which the team have taken forward during the last year. Because of the urgency and the nature of the issues in relation to COVID, the team were asked to develop a very specific system in relation to the priorities around COVID. And within a period of 2 months, during last year, they worked day and night to establish a system very specifically to help the management and overview of the type of monitoring, track and trace system for COVID. Some of the features of the system that they've developed very much link into the Dutch National Surveillance Centre, and allows active and passive contact tracing and contact monitoring, real-time national testing system, and allows negative results automatically to be sent to exposed people. So all of this sounds fairly familiar with some of the things that we are more than aware of, that we've been trying to attempt nationally and internationally in relation to COVID. Just to show very quickly some of the, again, screenshots of the type of system that they've been able very rapidly to develop over in the Netherlands, to cover all of the 25 GGD days, and allowing, for example, lab results to be fed in rapidly, those results to be acted on, and notifications sent out to individuals by SMS or email. So I'd like to close just by reading through this quote from the medical advisor to the US President, Dr. Fauci. The discipline of infectious diseases will assume added prominence in the 21st century in both developed and developing nations. To an unprecedented extent, issues related to infectious diseases in the context of global health are on the agendas of world leaders, health policymakers, and philanthropies. Now, it's important to note that that was from Dr. Fauci in 2001. So I'd just like to end by pausing and thinking and saying, if that had only really been the case over the past 20 years, we might have been in a slightly better position than the world might have been in a better position than we found ourselves about a year ago. So thank you for your attention. I'm afraid some of that was very rapid, and it's only just to give a very broad overview, a very skimmed view of technological development applied into a very important healthcare issue, which could well be explored in much more detail. I know that Dr. Karazaitri would be more than happy to explain and talk separately to anyone who might be interested in this type of approach and the work they've been doing recently. So thank you very much. I'm more than happy to engage in lots of discussion if that's raised questions.
Thank you so much, Professor Maton-Howarth, for that interesting and informative talk. So our first question is coming from when you were speaking about the 2010 plan, and maybe you've answered it a bit, but they were asking, was the system used as COVID emerged in the UK? If so, did it reach a stage of being overwhelmed?
Was it used when COVID emerged?
Yeah, when COVID emerged in the UK, and did it ever get overwhelmed if that was the case?
No, I don't believe that it was used particularly in the UK, and that's part of my comments at the end, as you say, that my feeling is that the potential, I think, a degree of lack of enthusiasm and forward-looking commitment from Public Health England, as it is now, to continued investment in the system. And I believe they had a potentially world-beating system back in 2010, that this could have developed further and further, and then potentially could have been in a position to actually be ready and available and much more useful in the UK when COVID emerged this time last year. As it is, I think that they weren't in the same position as they could, and that's why I was really referring to the work that the team had been able to develop to some extent with their collaborations in the Netherlands over the last few years, and to very rapidly, and I didn't stress it very much, but it's quite amazing really that within a period of 2 months or so, they were able to develop within June, July last year, this system very rapidly to work with the national surveillance system in the Netherlands. And given what we've heard yesterday from the Public Accounts Committee about the vast expenditure on the track and trace system in the UK, and what their belief that a lot of that vast expense has been perhaps wasted, it's a real frustration that I have, although it's nothing that I could have been involved with, as my involvement really ceased, as I said, and I left the Department of Health in 2012. So I wasn't able to take any official role in being able to see some of that potential development continue. And I feel somewhat frustrated that there was an opportunity lost.
Do you think the work in the Netherlands partly helps to explain the lower death rate in the Netherlands compared to next door Belgium?
Good question.
And that's from Professor Hani, so
yeah.
He's always asking good questions.
To be honest, I don't think I can scientifically really say whether or not. I mean, I would suggest that it has been an important contribution. I know from my days back, it went in my role as lead for public health research. We always looked in TB, for example, the strategies in the Netherlands, their public health system, we always looked at, and they had an excellent approach to going out, identifying infectious disease cases, and the strategies that they had for dealing with them were really very rigorous, and I think their approach to technology, and certainly the way in which they've responded to the ideas around this technology. The approach I tried to take was forward-looking. I was very lucky in the role that I had within the R&D director at the Department of Health at the time to have a budget and to play a role that was forward-looking in relation to the role of research feeding into the policy-making decisions and the policy-making machinery. But I think this type of innovation in 1998 would have struggled to get the funding to move it forward without some sort of forward-looking approach and to be slightly off the main course of the sort of funding mechanisms. So, and it was done in a very, very steady, stage-wise way. And it needs the sort of vision and the commitment and the championing to be able to help it move forward. My hope would have been that those ideas were sufficiently proven that continued development in R&D into the future would have allowed things to progress, and they have, certainly, but not as fast as they might. Sorry, I'm not sure. I'm going off of the slide.
Yeah, that's okay. So we've had lots of compliments and thanks for the insightful and helpful presentation from audience members. So the next question is, in countries where technology integrated health systems are not advanced and have limited resources, where should they start? And in which areas universities such as Brunel and other institutions from Western countries, how could they help collaborate in countries with technology integrated health research systems that aren't as advanced or are more limited?
Sure. Well, this is always a big issue in technology. Technology for technology's sake is always a big issue and a big problem. And the cost of technology. And certainly in low-income countries, developing countries, the need to think about appropriate technology and the beneficial implementation of technology. So the big high-cost technology with all the bells and whistles is something that sometimes the West can afford, but not necessarily use its funding in an optimum way. So it's always a difficulty, and the key balance to be struck is finding the ways in which you can identify beneficial implementation of technologies to get the type of improvements that you're hoping for, but within a cost-effectiveness structure. And so, one of the things that I was closely involved with when I first joined the R&D Directorate in the first 3 or 4 years in between 1990 and 95 was setting up health technology assessment, which was focused all about technological improvements, but making sure you help support the building of the evidence base about the benefits and the benefits at what cost. And still not quite answering the question, but I think in relation to how you implement into countries that really struggle to find funding to implement technology. Technology is a double-edged sword in some ways. It can allow leapfrogging. So if you find the right types of technologies that are not high cost, you can leapfrog and get improvements. But the whole essence of it is trying to establish the ways in which the technologies provide benefits. And so again, I come from a background where a lot of the work that I was doing in the Department of Health was focused on how do you build the evidence base behind technologies that supports you to be able to get a robust evidence base about the benefits of the implementations of those technologies. And that we do in this country within a certain cost framework, but a similar approach can be taken anywhere. So it's looking at what is the evidence in relation to the benefits that technology implementation can bring, but then at what are the costs associated with that, and then looking at that within the cost framework of the country that you're trying to implement it in.
Thanks, Bill. And then our last question is about the US. So the question is, the US has quite an expansive surveillance system. Does public perception and desire for surveillance vary across countries? Is it important to the UK public, for example?
Surveillance of what?
I mean, again, maybe related to some of what we talked about, these rumors that, you know, the vaccine's going to inject you with a microchip, or, you know, surveillance of disease. Even I'm thinking, I had a student who is HIV positive, and they were writing a personal statement, and it was reflected in their personal statement, and they were going to the US to study. And I said, you might not want to put that in there as public record, because in the US, you could, you know, be denied healthcare, you could be potentially fired from a job in some states. So maybe just in general about government keeping track of our health, and even with the vaccine. So
yes.
any question, any insight on that?
Well, that raises lots of really important sort of ethical related issues. If you're talking about individual surveillance, which allows specific individual monitoring from some sort of central government or whatever base to impinge on people's privacy, the surveillance at that level. When we're talking about surveillance at a national health, a public health level, often that's to allow the generation of knowledge, and that can be done in various ways. If that surveillance is anonymous, but still feeds into our increasing knowledge of what is happening in relation to the evolving diseases, the spread of the diseases, then that has real benefits nationally and to public health overall. So surveillance means many different things in different circumstances. But yeah, and I think if we're talking about technology in a generic sense, the implementation of technology, any technology, if it has potential ethical issues, then those are similarly issues that need to be considered at a societal level.
Well, thank you so much. A lot to think about as we conclude this talk. So I just want to thank everyone for attending this talk, for engaging with the entire webinar series on our global health challenges and opportunities, insight from the expert. And special thanks today to Professor Maton-Howarth. We really appreciate your time, and thank you again.
Okay, pleasure. Thank you.